an emergency responder. Can I help you?
Eric, come here.
Noah, can you hear me? Noah, can you hear me? Are you okay? Are you okay?
If you interact regularly with children, you know that accidents happen. Fortunately, most often these incidents are insignificant, resulting in simple scrapes and bruises. Children and parents generally accept that minor injuries and illnesses are a part of growing up. However, there are times when children suffer from significant medical problems. Automobile accidents, serious falls, choking, serious bleeding, near drowning, poisoning, and allergic reactions can be very frightening and devastating for children, parents, and rescuers alike. By becoming an emergency responder and learning how to handle situations involving injured or ill children, you are empowered to make a difference. You can't control all the variables, but you can offer assistance that may improve a child's chances of a positive recovery. If you're willing to help, you can become an important link between the problem's onset and the arrival of professional medical personnel. Again, you can't guarantee the final outcome, but you'll know that you did all that could be done. As you'll learn throughout this course, emergency procedures are easy to remember. By approaching each medical emergency following the same steps in the same order, you can provide basic life support in the correct priority of care. These steps are consistent with the priorities used by medical professionals. For life-threatening emergencies, your quick action can start a child down the road to recovery and make for a smooth transition to professional care. In this course, you'll also learn how to deal with injuries and illnesses that are not immediately life-threatening. You always start with primary life-threatening concerns to ensure there's no imminent threat, then go on to provide secondary care, first aid, that reassures and reduces the risk of further harm to a patient. The steps for this follow-up care can help you determine whether professional medical treatment is necessary or if basic first aid will solve the problem. Sometimes secondary care is as simple as properly bandaging a wound and setting the child back out to play. Emergency first response care for children follows the same priorities used by medical professionals. All emergency first response courses follow the emergency considerations and protocols developed by the various members of ILCOR, the International Liaison Committee on Resuscitation. Although Care for Children is an internationally based course, local variations in skill technique, first aid procedures, terminology, requirements, and course flow may exist. Your emergency first response instructor will guide you. This video supports the important background information learned from your Emergency First Response Participant Manual and what your Emergency First Response instructor will cover during the course. You'll watch the video or sections of it and review the related material in your participant manual. You'll do this either on your own or in class. During class, your Emergency First Response instructor will answer questions and demonstrate each skill. After watching his demonstration, then you'll practice each skill.
Hi, I'm an emergency responder.
Finally, you'll have the opportunity to apply what you've learned to simulate emergency scenarios created by your instructor. These take your skills to the next level by letting you analyze situations, form a plan, and then adapt based on what happens, just like you would in a real emergency. In the Care for Children course, you'll learn 12 total primary and secondary care skills with an emphasis on considerations for a child's or infant's physiology and anatomy. Skill 1, Scene Assessment and Barrier Use. Skill 2, Primary Assessment. Skill 3, Child CPR. Skill 4, Infant CPR. Skill 5, Bleeding Management. Skill 6, Shock Management. Skill 7, Spinal Injury Management. Skill 8, Conscious Choking Child. Skill 9, Conscious Choking Infant. Skill 10, injury assessment. Skill 11, bandaging. Skill 12, illness assessment. Your instructor may also orient you to automated external defibrillator, AED, use for children. Emergency First Response courses are skill-intensive. However, skills alone are not enough. Knowing how, why, and when to apply your skills during an emergency is important as well. The definitions and background information outlined in this section will give you the confidence to use your skills, knowing you are giving the correct care in the correct sequence. Providing specific emergency care for a patient is in part guided by the age of the individual. For this reason, the emergency care outlined in this course is divided into adult, child, and infant. Adults are defined as individuals typically older than 12 years, past puberty. Children are defined as individuals between the ages of 1 year and the onset of puberty, approximately 12 years old. Infants are defined as individuals younger than 1 year. When actually delivering emergency care, if you're in doubt as to whether the patient is an adult or a child, treat the patient as an adult. Primary means first in a series or sequence. It means most important. An assessment is an evaluation or an appraisal. Therefore, in terms of emergency care, a primary assessment is an emergency responder's first evaluation of an injured or ill child.
Gracie, are you okay?
Primary assessment is always the first step of any emergency care. Primary assessment also refers to the evaluation of a child for any life-threatening conditions needing immediate attention. Injuries and illnesses that are life-threatening need to be treated first. CPR stands for cardiopulmonary resuscitation. Cardio means heart, and pulmonary means concerning the lungs and breathing. Resuscitation means to restore or revive. In this context, resuscitation means to restore normal breathing after cardiac arrest. CPR is a two-step process. First, you press on a child's chest. These are called chest compressions. Second, you blow in the child's mouth, providing him oxygen. These are called rescue breaths. Rescue breaths can be delivered by mouth-to-mouth or mouth-to-mask. On young children and infants, rescue breaths can be delivered by sealing your lips tightly around the mouth and the nose. Complete CPR combines manual chest compressions with rescue breathing. The heart pumps oxygen-rich blood throughout the body. It also returns the oxygen-poor blood to the lungs for more oxygen. If a child's heart has stopped, rescue breaths alone are ineffective. If a child's heart has stopped, the most important action you can take is to substitute manual chest compressions for the heart's pumping action to circulate blood through the body. Rescue breaths can also aid in providing the child patient with additional oxygen. Chest compressions manually force blood from the heart through the arteries and deliver oxygen-rich blood to vital organs. These manual chest compressions deliver no more than 1/3 of normal blood flow to the body. Therefore, as an emergency responder, you quickly begin compressions and minimize interruptions during CPR. CPR is used as an interim emergency care procedure until the heart's normal rhythm is restored or more advanced care can be given. CPR extends the window of opportunity for resuscitation, increasing the child's chance of revival. That said, CPR rescue efforts are difficult to sustain for long periods and are exhausting, even with children. This is another reason to call for professional help immediately. To reduce fatigue, change rescuers every few minutes. Switching rescuers will reduce deterioration of chest compression quality. Regarding CPR, if you are unable or feel uncomfortable giving a non-breathing child rescue breaths, relax. Simply give the child continuous chest compressions without rescue breaths. Chest compressions alone are very beneficial to a child who is unresponsive and not breathing normally. Your efforts will still help circulate blood that contains some oxygen. Remember, adequate care provided is better than perfect care withheld. You will learn child and infant CPR during your skill development sessions. Unresponsive children who are not breathing normally may be in cardiac arrest. Rapid recognition of cardiac arrest is very important. After you've determined that a child is unresponsive and not breathing normally, activate EMS immediately and begin CPR. What does unresponsive mean? A child who is unresponsive shows no sign of movement and does not respond in any way to stimulation, such as a tap on the collarbone, pinch of the skin, or loud talking. Talking loudly or tapping the child allows you to survey the child's responsiveness. To check the responsiveness of an infant, you tap or pinch them and shout their name.
Gracie, are you okay?
You will learn how and when to deliver a responder statement and check for responsiveness during the skill development sessions. What does not breathing normally mean? If you don't see the chest rising, hear the air coming from her mouth, or feel air on your ear, then the child is not breathing normally and needs emergency care immediately. Further, an unresponsive child taking infrequent and sporadic, slow and noisy gasps is also not breathing normally. You will learn how and when to perform a check for breathing during the skill development sessions. The air we breathe contains 21% oxygen. We use about 5% for ourselves. This leaves a very high percentage of oxygen in the air we exhale after each breath. The unused oxygen can be used for rescue breathing to support a non-breathing child. You will learn how to perform and will practice giving rescue breaths during your skill development and scenario practice sessions. The chain of survival illustrates the 4 links of patient care. It emphasizes the teamwork needed in emergency situations between you and professional emergency care providers. When you recognize a potentially life-threatening emergency, you help with the first 3 links in the chain of survival. The 4th link involves professional emergency care providers only: EMTs, paramedics, nurses, and doctors. Let's look at each of the 4 links in the chain of survival. As an emergency responder, you must first recognize that an emergency exists. Once you've determined that an emergency exists, evaluate the scene to determine if it is safe for you to assist the child. If it is safe for you to assist the child, you next determine if the child is responsive and breathing normally. In most situations, you then provide emergency care and call for help. This first link in the chain of survival involves you, the emergency responder.
4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
A child who is unresponsive and not breathing normally needs CPR immediately. Early CPR, cardiopulmonary resuscitation, is the best treatment for cardiac arrests until a defibrillator and more advanced trained professionals arrive. Effective and immediate chest compressions prolong the window of time during which defibrillation can effectively occur and provide a small amount of blood flow to the heart, brain, and other vital organs. Immediate CPR can double or triple a child's chance of survival when experiencing a sudden cardiac arrest. This second link in the chain of survival also involves you, the emergency responder. Combined with CPR, early defibrillation by you, the emergency responder, or EMS personnel, significantly increases the probability of survival of a child who suffers a sudden cardiac arrest. During this course, you may learn how to use an automated external defibrillator, or AED. If you witness a cardiac arrest and an AED is available, you should begin chest compressions and use the AED as soon as possible. When applied to a child in cardiac arrest, an AED automatically analyzes the child's heart rhythm and indicates if an electric shock is needed to help restore a normal heartbeat. By learning how to use an AED in this course, this third link in the chain of survival involves you, the emergency responder. EMS personnel and hospital staff can provide advanced patient care that you cannot. The advanced care EMS personnel and hospital staff can provide includes artificial airways, oxygen, cardiac drugs, and surgical interventions. After initial on-scene care, EMS personnel take the child to the hospital for more advanced medical procedures. The child remains hospitalized until no longer needing constant, direct medical attention. If you are ever in a situation where you can help another in need, nervousness will be natural, especially when helping a child or an infant. Your nervousness can make it difficult to remember what to do and how to do it. To help you remember what to do, the memory word ABCABS can be used to remind you of the pathway and priorities of emergency care. By learning this memory word, you'll know what to do first, second, third, and so on when a child with a life-threatening illness or injury needs you. The meaning and prioritized flow of ABCABS is as follows. Within the AB portion of the memory word, the first A in ABCABS stands for airway. Essentially, the A reminds you to ask the question, is the patient's airway open? Also within the AB portion of the memory word, the first B in ABCABS stands for breathing. This letter reminds you to ask the question, is the patient breathing normally? In the cycle of care, you begin by initiating a very quick check of the patient, attempting to answer these two questions. Is the patient's airway open and is the patient breathing normally? If the patient's airway is open but he or she's not breathing normally, then you call emergency medical services and quickly move into the cycle of care. Within the memory word ABCABS, the CAB portion of the word reminds you how to perform CPR. Let's see how. CAB stands for chest compressions, airway open, and breathing for the patient. When a patient's not breathing normally, you must act immediately to provide chest compressions. After chest compressions, you open the patient's airway, then breathe for the patient. As defined earlier, this is how CPR is administered. After breathing for the patient, you continue to move through the cycle of care by returning back to chest compressions, opening the airway, and breathing for the patient. You continue with the cycle of care until professional help or an automated external defibrillator, an AED, arrives. During this course, you may learn how to use an AED in combination with CPR. If the patient is breathing normally, you move along the cycle of care to the S portion of CABS. The S in CABS reminds you to look for and treat serious bleeding, shock, and spinal injury. You will learn how to handle these three life-threatening emergencies in this course. If you encounter a child who needs primary emergency care and you've assessed the scene for your own personal safety, you should render assistance immediately. Even seconds count. Time is critical. The chances of successful resuscitation diminish greatly with time. When a child is unresponsive and not breathing normally, irreversible brain damage can occur within minutes. Julian? Besides providing an act of kindness toward a child in need, there are three basic reasons for assisting someone who needs emergency care. 1. You can save or restore a child's life. 2. You can help reduce a child's recovery time, either in the hospital or at home. And 3. You can make the difference between a child having a temporary or lifelong disability. Some individuals, even when CPR and first aid trained, hesitate to provide emergency care to those in need. This is understandable, and there are legitimate concerns on the part of emergency responders when helping those with injuries and illnesses. There are 6 common reasons why people hesitate to provide emergency care. Let's look at each. One reason people hesitate to help a child in need is anxiety. People may hesitate due to general nervousness or anxiousness. This is a perfectly normal reaction when helping those in need, especially a child or infant. However, as we've said, trust your training. When you follow the priorities of care, as outlined in this course, you are giving a child the best chance for survival or revival. A second reason people hesitate to help is guilt. People may hesitate when thinking about how they might feel if the child doesn't recover after delivering first aid. You can't guarantee that a child will live or fully recover. There's too much beyond anyone's control. Be confident that any help you offer is a contribution to another human being and has the potential to make a difference in the child's outcome. Even in the worst of outcomes, you can take comfort in the fact that you used your skills and gave the child more of a chance than he had alone. A third reason people hesitate to help is fear of imperfect performance. People may hesitate because they feel they cannot properly help an injured or ill child. This is seldom true that the smallest error will hurt or kill a child. During this course, you will learn what's critical and what's not. If you focus on perfection, you'll have a tendency to do nothing in a real emergency. Do not get caught in that trap. It's not hard to provide adequate care, and adequate care provided is always better than perfect care withheld. A fourth reason people hesitate to help is fear of making a child worse. The most serious medical emergency is when a child is unresponsive and isn't breathing normally. Sometimes people hesitate to help such a child, fearing that they will make him worse. As an emergency responder, realize that you cannot make such a child worse. A child who is not breathing normally and is unresponsive is already in the worst state of health. You can trust your training. Take a moment to relax, think of your training, then step forward and help. To help you remember your training, Emergency First Response has developed an easy-to-use prompt to remind you of the important steps needed to assist someone in need. The Emergency Care at a Glance Decision Guide provides you with comprehensive primary and secondary care directions. This is a must-have addition to your first aid kit at home and on the road. The fifth reason people hesitate to help is fear of infection. People may hesitate because they are afraid of being infected by or infecting the child they are assisting. Keep in mind that a large percentage of all CPR is performed in the home or for a loved one or friend. In these cases, risk of infection is low and fear of infection should not cause you to withhold CPR or emergency care. Infection is a concern, but your training includes learning to use protective barriers to minimize the risk of disease transmission. By using barriers, you're highly unlikely to get any disease or infection from someone you help. Further, research has shown that the chance of disease transmission is very rare when providing CPR. The sixth and last reason people hesitate to help is responsibility concerns. People may hesitate because they're afraid of being sued. In general, the fear of being sued should not stop emergency responders from providing emergency care. In many regions of the world, Good Samaritan laws, or regional equivalents, have been put in place to encourage people to come to the aid of others. When a child is in need of emergency care, you should render assistance immediately. Even seconds count. Good Samaritan laws, or regional equivalents, are enacted to encourage people to come to the aid of others. In general, they protect individuals who voluntarily offer assistance to those in need. They are created to provide immunity against liability. Often a Good Samaritan law imposes no legal duty to help a stranger in need. However, local laws may vary on this point, and in some areas people are required to provide aid. There may not be Good Samaritan laws in your local area. It would be wise to determine the extent and use of local Good Samaritan laws. Your Emergency First Response instructor may be able to provide you with information about Good Samaritan laws in your local region. In general, there are 6 ways you should act to be protected by Good Samaritan laws. They are: 1. Only provide care that is within the scope of your training as an emergency responder. 2. Ask for permission to help. 3. Act in good faith. 4. Do not be reckless or negligent. 5. Act as a prudent person would. 6. Do not abandon the child once you begin care. The exception to this is if you must do so to protect yourself from imminent danger. Helping a child in need is satisfying and feels good. Depending on the circumstances, however, it may also produce a certain amount of stress and some fearfulness. When the patient is a child or infant, emotions may be intensified. In many cases, a little stress may actually assist you when helping children by preparing you physically and mentally. When a child is seriously injured or ill, there are many aspects that are beyond your control. Attempting to take on the enormous responsibility of fixing everything is overwhelming and often the reason people hesitate to help. You need to accept that the care you provide may make a difference, but realize that the ultimate outcome is beyond your personal influence. Providing emergency care is no guarantee that a child's condition will improve or that the child will recover. In life-threatening situations, the aid you provide may extend the window of opportunity for the child to be revived. Each link in the chain of survival plays a part, yet no link bears the burden of success. Don't think that the final outcome is your responsibility. It's not. You should feel good about providing whatever emergency care you can. You should never fear harming a child that is unresponsive and not breathing normally by giving the child CPR. A child that is unresponsive and not breathing normally is already in grave danger. Remember that adequate care provided is better than perfect care withheld. When assisting an injured or ill child, try to approach an accident scene or medical emergency as calmly as possible. Your body will react to the situation by releasing adrenaline. Use this boost of energy to act quickly, yet remain in control. Be aware that you may not only need to deal with a frightened, injured child, but also with frantic parents or other adult guardians. Calm and controlled action helps everyone focus on assisting the child. Keep these things in mind anytime you approach a child in need of emergency care. Always speak slowly and clearly. Reassure the child and parent or guardian that you can help. One way to do this is to give your emergency responder statement to older children or to parents and guardians of infants. Use simple questions and age-appropriate phrases. Be gentle and explain what you are doing. Attempting to calm a child's emotions when they are injured or ill will go a long way in helping the child while you also provide emergency care. Think about how much a child changes in the first 8 years of life. An infant has a relatively large head compared to a small body with limited coordination. A healthy 8-year-old could be tall with good muscle tone and great coordination. Growth and maturity rates differ drastically between birth and age 8. Because there can be wide variations in children, you need to consider a few differences to help you determine how to best handle an emergency situation involving a child. These differences include age, size, ability to understand circumstances and communicate, plus mental state and willingness to cooperate. Although it's not critical for you to know the child's exact age, procedures do vary when handling an infant versus a child. Also, children who appear to be older than 8 years may be better handled using adult emergency care procedures, whereas a small 10-year-old may be perfectly cared for using child procedures. Use age as a general guideline. A key to determining which emergency care protocol is appropriate is to first look at the child's size, and second, to compare the child's size to your size. An infant or toddler probably won't be able to describe what happened or explain symptoms. Older children may be able to answer direct questions, but you still may need to depend heavily on what you observe. When a child is frightened and in pain, it may be difficult to get the child to calm down and let you help. This may be especially true if you're a stranger to the child. It's important for you to speak calmly and approach the child gently to avoid causing more distress. When an injured or ill-responsive child needs emergency care, ask permission before you assist them. With children that cannot talk, ask parents or guardians for permission to help. Asking for permission to help reassures parents, guardians, and children that can understand your meaning by indicating that you are trained appropriately. When dealing with children who can speak, parents and guardians ask for permission to help using the responder statement. You simply say,
Hi, I'm an emergency responder. May I help your child?
Yes.
It's important to get the agreement from parents, guardians, or from older children if they are alert and responsive. If the parent, guardian, or child agrees, or the child doesn't respond, there is implied permission, meaning you can proceed with emergency care if the child is unresponsive. If an injured or ill-responsive child refuses emergency care, do not force it on them. The same holds true for parents or guardians that refuse care.
Emergency responder, may I help your child?
No, we've already got it covered.
What happened?
If possible, talk with the child and monitor his condition by observation without providing actual care. You could, however, activate EMS at this time. This Care for Children course teaches you to assist children with life-threatening problems. It also teaches you to assist injured or ill children by offering first aid and support while waiting for emergency medical service or EMS personnel. Secondary care, first aid, prepares you to render emergency care for common medical problems that are not immediately life-threatening. As you learned earlier, anytime you approach a child to provide emergency care, regardless of the injury or illness, you perform a primary assessment and monitor the child using the cycle of care. During this portion of your Care for Children course, you'll review the cycle of care, assuring that there is no imminent threat to the child's life. Then, practice providing secondary care that reassures the child, eases pain, and reduces the risk of further harm. If EMS is nearby, you may never need to use the secondary care skills. However, if EMS is unavailable or delayed, or there is time and distance between the child and professional medical care, you may need to use the secondary care first aid skills. Secondary means second in a series or sequence. An assessment is an evaluation or appraisal. Secondary assessment is your second evaluation of an injured or ill person. Once a child is stabilized during primary care, you attend to the next level of emergency care, secondary care. This is the care you provide to a child with injuries or illnesses that are not immediately life-threatening. During skill development, you'll practice injury assessment that helps you determine the location and extent of all the child's injuries. You'll also learn the steps for illness assessment that'll help you identify and report medical problems that affect a child's health and may aid in treatment. Throughout this video, you've heard the words injury and illness. When discussing secondary care, it's important to understand exactly what these terms mean. An injury is defined as physical harm to the body. Examples include cuts, scrapes, and bruises, chest wounds, head, eye, and dental wounds, dislocations and fractures, temperature-related problems such as burns, and electrical injuries. An illness is an unhealthy condition of the body. Illnesses may be caused by pre-existing conditions such as allergies, heart disease, or diabetes. They may also occur due to external factors such as breathing toxic fumes or ingesting poison. Generally, illnesses are determined by looking for clues or signs that the child's body is stressed and also by listening to the child describe the symptoms. Assessment first aid is the treatment of conditions that are not immediately life-threatening. Uncovered during either an injury assessment or an illness assessment, 2 assessments you'll learn in your Care for Children course. For example, applying a bandage to a wound or wrapping a shivering child in a warm blanket is assessment first aid. Although the emphasis of secondary care is on rendering emergency care until EMS arrives, you'll find that you may also use your skills to handle common minor medical problems. Cleaning and dressing a child's scrapes is assessment first aid. Placing a cool compress on a family member's head to relieve flu symptoms is also assessment first aid. In every situation that involves injury and illness, you'll follow the sequence and steps that you learn and practice in this course. For emergency care and first aid information that is more specific, for example, what to do for snake bite, use the reference section of your Emergency First Response Participant Manual. When you come across a possible medical emergency, what's the first thing you do? It may surprise you that the first thing you do is think about yourself. You need to protect yourself. This is for the sake of the child needing help as well as for yours. After all, if you get hurt, you can't help. To fully protect yourself, you conduct a scene assessment and put on barriers. Assessing a scene is the process of looking for and avoiding any dangers at the scene of a medical emergency. It's the first thing you do and the first skill you'll practice.
Jaden? What happened?
Scene assessment takes 3 steps: stop, think, and then act. Stop and assess the scene for hazards. Ask yourself, what caused the injury? Are there any hazards? Look for potential hazards such as leaking gas, chemicals, radiation, down electrical lines, fire, firearms, the possibility of explosion, or oxygen depletion. Can you make a safe approach? Consider how to make a safe approach. Be alert for possible dangers such as oncoming traffic. Do you need to turn off a car's engine? Apply barriers as appropriate and if available. Next, think. Formulate a safe action plan. Can you remain safe while helping? Remember that your safety must be the first priority. Know your limitations. What emergency care may be needed? How can you activate local emergency medical services? Can you locate an AED? Can you have bystanders activate emergency medical services or locate an AED? Think about your training and relax. Now, act. Provide care and alert EMS. To act, follow the emergency care guidelines you will learn in this course. As you help, follow the emergency first response skill sequence of priorities. But scene assessment and taking care of yourself never stops. Ensure your safety so you can help others in need. To further protect yourself, you can greatly reduce infection risk by applying barriers. Barriers include gloves, ventilation shields, ventilation masks, face masks, and eye shields. Gloves and ventilation shields or masks are useful during CPR. Gloves, face masks, and eye shields are useful barriers when exposed to body fluids such as blood. As important as they are, however, do not delay emergency care if barriers are not available. Research has shown that the chance of disease transmission is very rare when providing CPR. Nevertheless, you can minimize the risk of infection by always placing a barrier between you and the body fluids of injured or ill persons. Since gloves are a very commonly used barrier, here's how to appropriately put them on and take them off. As you are assessing the scene, put on gloves if you have them. Put the gloves on carefully to avoid tearing. Removing your gloves once you are finished treating a child is a bit more involved. Your objective is to remove them so that you don't spray or spread body fluids. To remove the first soiled glove, carefully pinch the outside portion of the glove at the wrist, like this. Next, gently roll the glove off so the outside portion is turned inside out. Hold the removed glove with the gloved hand like this. To remove the remaining glove, place the ungloved hand under the glove at the wrist next to the skin and roll off in the same manner. To finish, roll this second glove off and around the previously removed glove, like this. Finally, place gloves with body fluids on them in a biohazard bag for disposal according to local guidelines. Your instructor will show you how to use one or more of the different ventilation shields and masks available. These barriers trap or isolate you from moisture or fluids from the child's breath and mouth during the rescue breathing step of CPR. Barriers take up little room, so it's easy to keep a set handy at all times, but remember, the chance of disease transmission is very rare when providing CPR. The risk of infection may be even lower if you're helping someone who has a medical history you know, like a family member. Therefore, you may not need to withhold aid just because you don't have a barrier. You've assessed the scene and perhaps you've applied your barriers. Now you're ready to begin primary assessment. Primary means first in a series or sequence. Assessment is an evaluation or an appraisal. Primary assessment helps you recognize life-threatening conditions and prepares you to provide priority emergency care. By conducting a primary assessment, you'll be able to answer the questions, is the airway open and is the child breathing normally? This is the AB portion of ABCAB's memory word. After you conduct a primary assessment, you proceed immediately to attend to any life-threatening conditions you discover. No matter what the child's situation when you arrive, you begin with a primary assessment. Primary assessments all follow the cycle of care sequence that speaks directly to a pathway of priorities for emergency care. Throughout an incident, you continually monitor the child and use the cycle of care to guide you, ready to provide assistance based on what you learned from your assessment. Let's look at a primary assessment first with a responsive child and then with an unresponsive child. A responsive child is one who is alert and able to answer questions. Begin with assessing the scene. Stop, think, then act. Next, give the responder statement.
Okay, I'm an emergency responder. May I help your child?
Yes.
If the patient is a young child or infant, you might need to ask a parent or guardian if you can help. Say, "Hello, my name is," your name. "I'm an emergency responder. May I help you?" Or to a parent or guardian, "May I help your child?" Because responsive children are crying, talking, moving, or making noises other than occasionally gasping, you verify that their airway is open and they are breathing normally. These are the first two steps in the cycle of care. This child is responsive and is breathing normally, allowing you to skip over the CAB portion of the cycle of care. There's no need for chest compressions, opening an airway, or breathing for the child. Keep the child still. Do not move the child unless you or the child's safety is compromised. Put on barriers if immediately at hand. However, don't delay emergency care if barriers are absent. Next, check for serious bleeding, shock, and spinal injury. As you move through the cycle of care, alert the emergency medical service if you find any serious medical condition. Now, let's look at primary assessment with an unresponsive child, that is, breathing normally. An unresponsive child is one who is either completely unconscious or one who may be partially conscious but incapable of response. Begin again by assessing the scene. Stop, think, and then act. Make sure it is safe to help the child. If the child is old enough to speak, give the responder statement.
My name is Eileen. I'm an emergency responder. May I help you?
Hello, my name is, your name. I'm an emergency responder. May I help you? If a parent or guardian is present, you need to ask them if you can help the child. If the child is not old enough to speak or doesn't respond to your statement, then tap her on the shoulder or arm and ask, "Are you okay?" With infants, pinch or tap them and shout their name to check responsiveness. After delivering the responder statement and noting that they are unresponsive, quickly check for an open airway and normal breathing. If you are unsure if the child's airway is open or if she is breathing normally, quickly open the child's airway using the head tilt chin lift. To perform a head tilt chin lift, put your hand on the child's forehead and gently tilt his head backward while lifting the bony part of his chin with your fingertips. like this. Another method of opening an airway is the pistol grip, like this. When the child's airway is open, check for normal breathing. To do this, look for chest movement and listen for breathing sounds. Also, with your ear next to her mouth, feel for expired air on your cheek. This check for normal breathing must be accomplished quickly. If the child is not breathing normally, the child needs CPR immediately. Avoid long delays. If the child is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. With children, there are exceptions to the call first approach to emergency care. In these cases, you provide care for a short period of time, then call. Your instructor will highlight these exceptions. This unresponsive child is breathing normally, so continue your primary assessment by checking for serious bleeding, shock, and spinal injury. You'll learn how to manage these life-threatening problems in other skills. If a spinal injury is suspected, keep the child's head, neck, and spine immobilized and do not move them. If no spinal injury is found or suspected and you may need to leave the child, place her in the recovery position. The recovery position allows the child to breathe easier since there is little pressure on the chest. It also decreases the risk of something blocking her airway and allows fluids to drain should the child vomit. To put an unresponsive breathing child in a recovery position, first, position her arms like this. Next, grab the child's far leg just above the knee and pull it up, keeping the foot on the ground, like this. Now, gently pull the child toward you, putting her on her side. Once on her side, place the child's hand near or under the neck for stabilization. If need be, gently pull back on the child's head to assure an open airway. If the child has to be kept in the recovery position for more than 30 minutes, consider turning the child to the opposite side to relieve pressure on the lower arm. Continue to monitor the child's medical status using the cycle of care. When an unresponsive child stops breathing normally, her heart will be beating erratically or not at all. To help this child, you can substitute manual chest compressions for the heart's normal pumping action to circulate blood through the body. The blood you push through the child's body will carry some oxygen to important organs. Your willingness to respond may increase the child's chance for survival until emergency medical service personnel arrive. CPR is a two-step process. Step 1, chest compressions, followed by Step 2, rescue breathing. In this skill, you'll learn how to perform chest compressions and rescue breaths.
1, 2, 3, 4, 5, 6.
First, it helps to define that a child is an individual between the age of 1 year and the onset of puberty, approximately 12 years old.
Gracie!
As usual, begin by assessing the scene for safety.
Gracie, are you okay?
Next, check the child for responsiveness by giving the responder statement.
Gracie, it's Jill. I'm an emergency responder. May I help you?
Hello, my name is, your name. I'm an emergency responder. May I help you? If no response to your statement, then tap the child on the collarbone and ask, "Are you okay? Are you okay?" The collarbone is sensitive, and tapping it will reveal the level of responsiveness.
Are you okay?
Now, quickly check for an open airway and normal breathing. To open the airway, use the head tilt chin lift or pistol grip. Look to see if the child's chest is rising and falling. Can you hear the child breathing? Can you feel the child's breaths of air on your ear? If the child is unresponsive and not breathing normally, have bystanders call EMS if available.
Gracie is unresponsive and not breathing normally. Can you please go call for help?
If you are alone and no bystanders are present to call EMS, you need to provide care for the child first, then call EMS. Follow the resuscitation guidelines for your region as to how you provide this initial care and when to call EMS. Your instructor will guide you during skill practice. Now, place the child on his back if not already in this position. If necessary, expose the child's chest. Find the compression site by putting the heel of one hand on the lower half of the child's breastbone. This is the center of the chest. With small children, you may use one hand to deliver chest compressions, like this. If you can't push the breastbone down at least 1/3 of the depth of the child's chest, or approximately 5 centimeters or 2 inches, use two hands, as with adult CPR, like this. To deliver chest compressions, position yourself so that you are directly over your hand and your arm is straight. Lock your elbow, like this. Keep the force of your compressions straight down. Avoid pushing on the rib cage or the lower right tip of the breastbone. Carefully allow your body weight to deliver the compressions. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone at least 1/3 of the depth of the child's chest, approximately 5 centimeters or 2 inches. After each chest compression, release the pressure without taking your hands off the child's chest, allowing the chest to return to its normal position. Repeat your chest compressions at a pace of 1, 2, 3, 4, and so on, counting fast, for 30 compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard, push fast. After delivering 30 chest compressions, quickly position a ventilation barrier on the child if you feel the need to protect yourself or the child. Next, gently open the child's airway using the head tilt chin lift or pistol grip lift. With the airway open, pinch the nose closed or cover the nose with your mouth in very small children. Now take a normal breath and give the child 2 rescue breaths. Each breath should last about 1 second. Provide the child with just enough air to make his chest rise. Look for this rise in the child's chest. If you can't make the child's chest rise with the first breath, repeat the head tilt chin lift or pistol grip lift to reopen the airway before attempting another breath. Consider looking in the child's mouth for a visible obstruction that can be readily removed. If you cannot make the child's chest rise with rescue breaths, quickly return to chest compressions. Only attempt 2 rescue breaths. After delivering 2 rescue breaths, immediately begin another cycle of 30 chest compressions. Minimize delays in providing chest compressions. When a child is unresponsive and not breathing normally, you now know how to deliver CPR, chest compressions combined with rescue breaths. That's a great start, but you may be able to help further by using an AED. An AED is a sophisticated battery-powered microprocessor-based device that incorporates a heart rhythm analysis and a shock advisory system. AEDs can automatically and reliably deliver a shock to a child who is not breathing normally and whose heart has an abnormal rhythm. The electrical shock from an AED can momentarily disrupt the abnormal heart rhythm and allow the heart's normal heartbeat to return. Once a normal heartbeat returns, blood can again begin to flow to the brain and body organs. Administering an electrical shock from an AED is called defibrillation. Prompt defibrillation of a child's abnormal heart rhythm is a vital part of the chain of survival. The following overview provides you with a generic and universal procedure used by most AEDs. AEDs manufactured by different companies operate differently. Your instructor will guide you on the specifics of the AED used in your course. AEDs may be used on children, but not infants. When confronted with an unfamiliar AED model, refer to the manufacturer guidelines and instructions prior to needing the AED during an actual medical emergency. Even if you find yourself having to use an unfamiliar AED model, don't worry. Most are intuitive and very easy to use. AEDs are simple to operate because they have voice and visual prompts to assist you with setup and treatment of a child in need. If while delivering CPR to a child, a bystander can retrieve an AED, direct them to do so. Once the person arrives with the AED, have them set it up and place the chest pads on the child while you continue CPR. This minimizes interruptions of chest compressions. If you are alone and know where to find an AED close by, leave the child to quickly secure the AED. Once an AED is secured, Position the AED close to the child's ear on the same side as you, the rescuer. Turn the AED power on and follow the device prompts exactly. Bare the child's chest. If the child is wet, consider quickly drying the chest prior to pad placement. Remove the defibrillator pads from their packaging. As directed by the manufacturer, place defibrillator pads on the child's bare chest, adhesive side down. Note the placement illustrations on pad packaging or pads themselves. Some AED manufacturers use child-specific defibrillator pads and machine settings. If so, follow the manufacturer's directions. If child pads are not available or the AED does not have a child key or switch, use the adult pads or adult settings. When using adult pads on a child, ensure that the pads do not touch each other on the child's chest. For best shock results, some manufacturers illustrate placement of child-specific pads different than adults. With children, typically one pad goes here, a second pad typically goes here. Plug in the AED pads if needed or prompted. Almost immediately, the AED will begin to analyze the child's heart rhythm, although some AEDs require you to push an Analyze button. Clear rescuers and bystanders from the child, making sure no one is touching the child. Also, make sure no equipment is touching the child. Say, "I'm clear, you are clear, everyone is clear." If the AED advises that a shock is needed, the responder should follow the prompts to provide one shock, followed by CPR. If the AED does not advise a shock, immediately resume CPR. After a period of CPR, the AED will again analyze the child's heart rhythm. If a normal heart rhythm is still absent, the AED may prompt you to deliver another shock. Most AEDs will wait 2 minutes before analyzing and shocking the child again. During that time, continue CPR. As prompted, continue to give single shocks combined with CPR until the child resumes breathing, relieved by EMS personnel, or you are physically unable to continue. If the child begins breathing normally, support the open airway and continue to use the cycle of care to monitor the medical status. When an unresponsive infant stops breathing normally and his heart is beating erratically or not at all, you can substitute manual chest compressions for the heart's normal pumping action to circulate blood through the body. The blood you push through the infant's body will carry some oxygen to important organs. Your willingness to respond may increase the infant's chance for survival until emergency medical service personnel arrive. CPR is a two-step process. Step 1, chest compressions, followed by Step 2, rescue breathing. In this skill, you'll learn how to perform chest compressions and rescue breaths. First, it helps to define that an infant is a baby who is younger than 1 year. As usual, assess the scene for safety. If a parent or guardian is present, ask if you may assist the infant. Check the infant for responsiveness by pinching or tapping the infant along with shouting his name. Next, quickly check for an open airway and normal breathing. If the infant is unresponsive and not breathing normally, have bystanders call EMS if available. If you are alone and no bystanders are present to call EMS, you need to provide care for the infant first, then call EMS. Follow the resuscitation guidelines for your region as to how you provide this initial care and when to call EMS. Your instructor will guide you. Now, place the infant on his back if not already in this position. Make sure the infant is laying on a firm surface, not a mattress. You may also cradle the infant in your arms, like this. Locate the chest compression site. If necessary to find the compression site, expose the infant's chest. Find the compression site by putting 2 fingers on the breastbone, just below the nipple line. Deliver the chest compressions. With your 2 fingers, push straight down on the infant's breastbone. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone at least 1/3 of the depth of the infant's chest. With infants, this equates to a depth of approximately 4 centimeters or 1.5 inches. After each chest compression, release the pressure without taking your fingers off the infant's chest, allowing the chest to return to its normal position. Repeat chest compressions at a pace of 1, 2, 3, 4, and so on, counting fast for 30 compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard. Push fast. To deliver rescue breaths, first open the infant's airway. Use one of two common methods: head tilt chin lift or pistol grip lift. Open the infant's airway with a gentle movement. Avoid tilting an infant's head back too far, as this may actually block the infant's airway. With the infant's airway open, take a breath yourself. Cover the infant's mouth and nose with your mouth. If your mouth is too small, simply put your mouth over the infant's nose and hold his mouth closed to prevent escaping air. Now, give the infant 2 rescue breaths. With infants, rescue breaths are more like puffs of air. Each breath should last about 1 second. Provide the infant with just enough air to make his chest rise. Look for this rise in the infant's chest. If you can't make the infant's chest rise with the first breath, repeat the gentle head tilt chin lift or pistol grip lift to reopen the airway before attempting another breath. Consider looking in the infant's mouth for a visible obstruction that can be readily removed. If you cannot make the infant's chest rise with rescue breaths, quickly return to chest compressions. Only attempt 2 rescue breaths. After delivering 2 rescue breaths, immediately begin another cycle of 30 chest compressions. Minimize delays in providing chest compressions. Continue CPR until the infant resumes breathing or until relieved by EMS personnel. If the infant begins breathing normally, support the open airway and continue to use the cycle of care to monitor the infant's medical status. Control of bleeding is a basic but important first aid skill. By controlling a child's serious bleeding, you can positively influence his medical outcome. Serious bleeding is life-threatening because blood carries oxygen to the body tissues. Losing even a small amount of blood can cause death. There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessels and carry blood from the heart to the tissues. Arterial blood is bright red and spurts with each heartbeat. Arterial bleeding is the most serious because the child can lose a lot of blood quickly. If a major artery is cut, death can occur in 1 minute if not treated. Activate the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark red and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the child's cycle of care. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding can be recognized when blood slowly oozes from the wound. Capillary bleeding is common when children get scrapes and scratches. Capillary bleeding may stop on its own or is typically easy to handle with direct pressure. Monitor the child's cycle of care and contact the emergency medical service if necessary. To begin helping a child with serious bleeding, first assess the scene to make sure it's safe for you to approach. Put on appropriate barriers and deliver your responder statement, asking the child, parent, or guardian if you can help. If given permission, begin providing emergency care. First, call emergency medical services. Reassure the child as you treat for bleeding, and if needed, assist the child into a position of comfort while treating. Since the child is responsive and breathing normally, you can sidestep CPR, chest compressions, opening an airway, and breathing for the child. With a responsive patient, proceed immediately to the S in ABCABS on the cycle of care. The first S in ABCABS prompts you to check for serious bleeding. To control serious bleeding, use sustained direct pressure. Put a clean cloth or dressing on the wound and apply constant pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. With non-severe bleeding, you may release direct pressure periodically to determine if bleeding has stopped or slowed. With severe bleeding, sustained direct pressure is important. In addition to sustained direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. Older children may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Applying sustained direct pressure and pressure bandages best controls bleeding. However, there may be regional treatment variations, such as elevating bleeding limbs, giving the child oxygen, and applying a tourniquet as a last resort to control serious bleeding. Your instructor will advise you of these variations. Shock is the body's response to serious injury or illness. Shock can be life-threatening, and it happens when not enough oxygenated blood reaches the body tissues. This occurs due to serious bleeding or when the body no longer regulates blood flow to the tissues. In general, always treat an injured or ill child for shock, even if the signs and symptoms for shock are absent. There are 9 indications of shock, though some occur with other injuries. They are rapid, weak pulse, pale or bluish tissue, moist, clammy skin, possibly with shivering, mental confusion, anxiety, restlessness or irritability, altered consciousness, nausea and perhaps vomiting, lackluster eyes, a dazed look, and shallow but rapid labored breathing. By the time you get to shock management, you will have progressed well along the cycle of care. You will have assessed the scene and applied your barriers. Through primary assessment, you would have confirmed the child's level of responsiveness and that she is breathing normally. Since the child is responsive and breathing normally, there is no need for CPR. If the child is unresponsive or bleeding, you would have already alerted the emergency medical service. If he were bleeding, you would have treated him by applying direct pressure. To treat a responsive child in shock, let the child determine what position is most comfortable, sitting or lying down. To treat an injured and unresponsive child, do so in the position you find him. If there may be a head, back, or neck injury, don't move the child and keep his head and neck immobile. More on spinal injury treatment in the next skill. Regardless of whether the child is responsive or unresponsive, to treat for shock, maintain the child's body temperature based on the local climate. This may mean covering the child with a blanket or protecting from sun exposure. If there's no reason to suspect spinal injuries or leg fractures, elevate the child's legs 15 to 30 centimeters, that's 6 to 12 inches. This shifts blood to the more critical chest and head areas. Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. With children, you should always suspect a spinal injury in situations involving a fall, severe blow, crash, or other strong impact. If you didn't see the injury occur or the circumstances surrounding an injury are not clear, look for these indications that may signal the need for spinal injury management. Change of consciousness, like fainting, difficulty breathing, vision problems, inability to move a body part, headache, vomiting, loss of balance, tingling or numbness in hands, fingers, and feet and/or toes, pain in the back or neck area. Moving a child with a head, neck, or spine injury may make the injuries worse. Therefore, never move a child with a suspected spinal injury unless absolutely necessary because of imminent danger. With a responsive child, conduct your primary assessment where you find him. You would only move the child to avoid immediate further harm, such as if the child were in the water or a burning car or building. You would also move the child, if necessary, to provide CPR. For an unresponsive child, start by assessing the scene for danger. Put on appropriate barriers if available, and begin to conduct your primary assessment. Conduct your assessment with the child in the position you find her unless the child's safety is in question. She might need CPR, or you need to control serious bleeding of a wound you can't see. Deliver your responder statement and have someone call emergency medical services. The child must be on his back for continued care. If he's not already on his back, you'll have to turn him while minimizing risk to his spinal cord. You want to stabilize the head and neck as you turn the child so that they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the child all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you under his hip, and while supporting his head, roll the child toward you. Gently ease the child onto his back and continue with the cycle of care by starting CPR if the child isn't breathing normally. If the child is breathing normally, check and treat for serious bleeding, shock, and spinal injury. Children learn by exploring their environments, often putting things like toys in their mouths. Older children are often in a hurry and at times swallow food without fully chewing. These situations can often lead to choking. In a primary assessment, you learn how to apply the cycle of care to ask two initial questions when a child is in need of emergency assistance. Is the child's airway open, and is the child breathing normally? When a responsive child is choking, they neither have an open airway nor are they breathing normally. A choking child needs immediate help to restore breathing. Let's learn how to help a conscious and unconscious child expel an object that's causing her to choke. If you believe a child is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive child, "Are you choking?" If the child is coughing, wheezing, or can speak, encourage the child to cough until she expels the object. If the child cannot speak or breathe, give the emergency responder statement and alert emergency medical services.
Are you choking? My name is Joss and I'm an emergency responder. May I help you?
After the child indicates she wants your help, a nod will do. You may use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. Techniques for handling a conscious choking child vary internationally. Your emergency first response instructor will teach you the techniques appropriate for your area. And it's those you should use when assisting a choking child. In general, however, there is no clear evidence that one technique is better than another, but there is evidence that if one technique does not help a choking child, another one might. To deliver back blows, take a position to the side and slightly behind the child. Supporting the chest with one hand, lean the child forward like this. A small child may be placed across your lap like this. Next, while supporting the child, deliver 5 sharp back blows between the child's shoulder blades using the heel of your hand. Continue the 5 back blows until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each back blow rather than to give all 5 back blows. After delivering the back blows, look in the child's mouth and carefully remove any visible objects. Abdominal thrusts use residual air in the child's lungs to blow the obstruction clear. To begin, stand, sit, or kneel behind the child with your arms around her waist. Find the child's navel with one hand. Make the other into a fist and place the thumb side against the child's abdomen slightly above her navel like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the child's ribs, pull your hands inward and upward in a thrusting motion. Continue the 5 abdominal thrusts until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each abdominal thrust rather than to give all 5 thrusts. Another technique used to assist a conscious choking child is chest thrusts. In some regions, chest thrusts may also be used on children who are markedly obese instead of abdominal thrusts. To begin to deliver chest thrusts, stand, sit, or kneel behind the child and place your arms around the body under the armpits. Place your chest against the child's back. Locate the chest compression site. This is the same compression site as CPR, over the lower third to half of the sternum. Next, make a fist and place the thumb side on the thrust site. Place the other hand over the outside of the fist. Perform up to 5 quick inward thrusts. These thrusts are similar to CPR compressions but sharper and delivered at a slower rate. Avoid putting pressure on the rib cage with your arms. Continue the 5 thrusts until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each chest thrust rather than to give all 5 thrusts. Continue using one or more of these techniques until the obstruction is relieved or the child becomes unconscious. If a responsive choking child becomes unconscious while you're trying to help, carefully help the unconscious child to the ground. Next, if you have not already done so, activate emergency medical services and immediately begin CPR, chest compressions. The compressions may dislodge any obstruction. After giving chest compressions, you should quickly look inside the child's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. Continue CPR until the obstruction is relieved and the child becomes responsive or emergency medical services arrives. When you practice these techniques in class, be sure to simulate thrusting. Never perform thrusts on a child who does not have an obstructed airway. With choking infants, begin with a scene assessment. Stop, think, and act. If appropriate, consider giving your responder statement to the parent or guardian asking their permission to assist the infant.
I'm an emergency responder. May I help you?
If the infant is coughing, wheezing, or crying, allow the infant to keep trying to expel the material on their own. However, if the infant is obviously choking but cannot cough, wheeze, or cry, they need immediate assistance. Begin by looking in the infant's mouth and carefully remove any visible objects. Should no visible objects be seen in the infant's mouth, use back blows to help the infant expel the object. First, position the infant face down on your forearm and support the infant's head and neck with your hand, like this. With the infant's head slightly lower than the body, deliver up to 5 distinct and separate back blows between shoulder blades with the heel of your hand, like this. The aim is to relieve the obstruction with each blow rather than to deliver all 5 back blows. If the object is not dislodged after 5 back blows, support the infant's head and turn the infant over. Keep the infant's spine straight while turning him over. Look in the infant's mouth and carefully remove any visible objects. You may consider administering chest thrusts if back blows are not effective. To perform chest thrusts on an infant, you may rest the infant on your arm or thigh by positioning his head lower than the body, like this. Next, locate the chest compression site. This is the same compression site as infant CPR. Provide up to 5 distinct chest thrusts. These are sharper in nature to CPR chest compressions and delivered at a slower rate. The aim is to relieve the obstruction with each compression rather than to deliver all 5 chest thrusts. Keep the force of compressions straight down. Avoid pushing on the rib cage or the lower tip of the breastbone. You may want to leave the other hand in position on the infant's forehead. After the chest thrusts, or if the infant begins to cry, look in the infant's mouth and carefully remove any visible objects. If the object is not dislodged, repeat back blows and chest thrusts. Continue until the object is dislodged and the infant begins to breathe, cry, or cough, or the infant becomes unconscious. If a responsive, choking infant becomes unconscious while you are trying to help, your forearm can also be used to support the infant. Next, yell out for help and assistance and begin CPR.
This baby is unresponsive and not breathing properly. Call for help.
Following each set of chest compressions, quickly look in the child's mouth and attempt to remove any visible obstruction. If an object is seen, you should carefully remove the object. If no object is seen or the object has been removed, proceed with 2 rescue breaths. Continue CPR, 30 chest compressions followed by 2 rescue breaths. After 5 sets of CPR, call EMS. Continue CPR until the obstruction is relieved or EMS arrives. During practice, remember that you never perform abdominal thrusts or chest compressions on an infant who does not need them. When trauma occurs, a complete injury assessment allows you to attend to and report both external and internal injuries that may affect a child's condition. Remember that you always begin with the cycle of care, checking to see if the child is responsive and breathing normally. As you approach the injured child, assess the scene. Stop, think, and then act. Use barriers as appropriate, check for responsiveness, and give your responder statement when needed. Call EMS and make sure you obtain consent from parents or guardians if necessary. Since you only perform an injury assessment on conscious, responsive children, make sure that you constantly explain to the child what it is that you're doing. Speak calmly and handle a frightened child very gently. First, stabilize the child's head and neck, instructing her to answer verbally without nodding or moving the head. Stop the assessment immediately if the child complains of head, neck, or back pain. In this case, continue to stabilize the spine and wait for EMS. Start your assessment at the head and work toward the child's toes. Feel for deformities on the child's face, gently running your fingers over the forehead, cheeks, and chin. Next, check the ears and nose for blood or other fluid. Again, if you suspect a head or neck injury, stop your assessment and wait for EMS. Check to see if the child's pupils are the same size and have her follow your finger with her eyes, without moving her head or neck. The eyes should move smoothly together. Feel the skull and neck for abnormalities. If the child complains or you find something, stop the assessment. If you can reach the shoulder blades, slide or place one hand over each shoulder blade and gently push inwards. Then move your hands outward to the shoulders and press gently inward with the palm. Next, run your fingers over the collarbones like this. You're looking for irregularities, blood, moisture, pain, or other unusual sensations. Place one hand on the shoulder to stabilize the arm and gently slide the other hand down the upper arm, elbow, and wrist. Repeat on the other arm and ask the child to wiggle her fingers and squeeze your hand. Note any weaknesses or differences in strength. Inspect the child's chest for deformity by placing the palm of each hand on one side of the child's rib cage. Press in gently. Next, gently put your hands under the child to check the spinal column. Cover as much area as possible without moving her. If you find any irregularities or pain in the spine, stop the assessment. Use one hand to gently push on the left and right of the child's abdomen, both above and below the navel. Next, move your hands gently over the hip bones to check for swelling or hardness, tissue softness, unusual masses, joint tenderness, and deformities. Avoid pushing inward on the hips. Move down the lower body, and starting with the thigh, slide your hand down the upper leg, knee, lower leg, and ankle just like you did with the arm. Make sure you ask the child to wriggle her toes and press the sole of her foot against your hand. Repeat this with her other leg. After your assessment, note areas of pain or abnormality and attend to any injury you can. Be prepared to report your findings to EMS personnel once they arrive. Continue to monitor the child using the cycle of care. Bandaging helps control bleeding, immobilize injuries, and reduce contaminants entering wounds. It's a skill that can make a child more comfortable or save her life, depending on the circumstances. Remember that you always begin with the cycle of care, checking to see if the child is responsive and breathing normally. As you approach the injured child, assess the scene. Stop, think, and then act. Use barriers as appropriate. Check for responsiveness and give your responder statement when needed. Call EMS and make sure you obtain consent from parents or guardians if necessary. If during your injury assessment you find an injury needing bandaging, Use this skill, especially if emergency medical service is either delayed or unavailable. First, locate or secure a first aid kit. Most kits have several types of bandages. Choose the best bandage based on the injury or make the best use of whatever is available. Apply roller bandages directly over a sterile dressing covering a wound. Remember, as a general rule, once you have a dressing in place, don't remove it. To apply the roller bandage, start below the wound and work upwards towards the heart. Wrap the bandage firmly and consistently, but don't make it too loose or too tight. Make sure you leave fingers or toes exposed so you can check circulation. Secure the end of the bandage by tucking, tying, or taping it in place. When bandaging a foot, secure the bandage by wrapping it around the ankle several times. Then, back over the injury site on the foot. Start a hand bandage in a similar fashion, working around the thumb and wrist. For elbow and knee injuries, wrap above and below the joint to stabilize the injury. Use a triangle bandage to support arm, rib, or shoulder injuries. First, place the long edge of the triangle over the shoulder on the uninjured side. Then bend the arm at the elbow and bring the forearm over the chest and bandage. Next, bring the lower end of the bandage over the shoulder on the injured side and tie it off in the back of the neck. Make sure you support the hand, but leave the fingers showing so you can check circulation. If you suspect broken ribs or you want to secure the arm firmly, use a second triangular bandage to hold the arm against the chest. Tie the bandage over the sling and around the chest. Illness assessment helps you find and report medical problems that affect a child's health and may assist treatment. You can use this skill to determine if EMS is necessary or to find out what first aid you can use to assist the child. You'll assess the child by asking questions and by checking the child's respirations, pulse rate, temperature, skin moisture, and color. As you've learned, you start your primary assessment. After giving the responder statement, assuring the child's lifeline, and obtaining parent or guardian consent, get something to write on so you can record what you find. An illness assessment sheet may be found in your participant manual. Infants and some children cannot answer the questions in the illness assessment. In these situations, parents and guardians may be the only sources of information. To help you to remember how to begin an illness assessment, use the mnemonic SAMPLE. SAMPLE stands for signs and symptoms, allergies, medications, pre-existing medical history, last meal, and events. The S stands for signs and symptoms. Signs are something you see is wrong with the child. Symptoms are things the child tells you is wrong. Ask how the child is feeling and what occurred immediately before they felt bad. Ask questions like, how do you feel now? When did you start to feel bad? What were you doing when you began to feel bad? And where were you when you began to feel bad? When looking for signs, check the child's pulse, respiration rate, and temperature. To find a child's pulse, use the radial artery. Find the artery on the wrist next to the thumb side of the hand. Slide 2 or 3 fingers into the groove on the wrist, immediately below the hand on the thumb side, and count the number of beats in 30 seconds. Then multiply this by 2 to get the pulse. The average pulse for a child is from 70 to 150 beats per minute. Determine if you would characterize the pulse as strong, rapid, or weak. To find an infant's pulse, use the brachial artery. Put your index and middle finger between the infant's elbow and shoulder on the inner side of the arm and gently push in. Count the number of beats in 30 seconds, multiply by 2. The average infant pulse ranges from 100 to 160 beats per minute. Again, determine if the pulse is strong, rapid, or weak. If you can't find a child's pulse, just move on with your assessment. Next, check the child's breathing. First, look for signs and symptoms of respiratory distress, such as strange noises, and the child complaining about pain, shortness of breath, or dizziness. When possible, simply watch a child's chest rise and fall and count respirations. If you cannot see the child's chest rise and fall, you will need to place a hand on the chest. Children often alter their breathing rate if they become aware their breaths are being counted. Therefore, use the technique shown here to mask your efforts and to obtain an accurate respiration count. Position the child's arm so that your hand rests on the child's abdomen. Count the child's respirations for 30 seconds and multiply by 2 to determine the respiratory rate. Average breathing rate for children is 18 to 40 breaths per minute, while infants breathe 30 to 60 breaths per minute. Determine whether respirations may be described as fast, slow, labored, wheezing, or gasping. Next, check temperature and moisture by feeling the child's forehead with the back of your hand. Characterize it as warm, hot, cool, moist, or clammy. You'll also want to check the child's color. Is it pale, gray, reddish, bluish, or yellowish? Does it have blotches? If the child has dark skin, you can check for color change in the nail beds, lips, gums, tongue, palms. Whites of their eyes and earlobes. The next part of the mnemonic sample is A, which stands for allergies. Ask the child or parent guardian if the child is allergic to anything, food, drugs, airborne matter, etc. Has the child ingested or taken anything they may be allergic to? Has the child been bitten or stung by an organism? If a severe allergic reaction occurs, treat as a medical emergency and follow primary care procedures. In severe allergic reaction, anaphylaxis can be treated by epinephrine, also known as adrenaline. Children who have suffered a prior episode of anaphylaxis often have prescribed for them an auto-injector of epinephrine. Have the child use the auto-injector or assist them with its use. In unusual circumstances when advanced medical assistance is not available, a second dose of epinephrine or adrenaline may be given if symptoms of anaphylaxis persist. Children who use an auto-injector should see a doctor. Next, the M in sample stands for medications. Ask the child if he takes medication for a medical condition. Try questions such as, do you take medicine? Or did you take any medicine today? How much? When? If possible, get the child's medication so you can turn it over to EMS. The P in sample stands for pre-existing medical history. Ask the child if he has any medical conditions like heart conditions, diabetes, or asthma. The L in sample stands for last meal. Ask the child when he last had a meal and what he ate. The last letter in sample is E, which stands for events. Ask the child or note the events leading up to the illness or injury. Now that you've practiced the 12 Emergency First Response Care for Children skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts to the situation. In this first scenario, the emergency responder witnesses an accident. The emergency responder begins by checking the child's responsiveness.
Diego, are you okay? This is Edgar. I'm an emergency responder. May I help you? Diego, are you okay?
If a bystander is available, have that individual go call for help. Next, he turns the child and begins a primary assessment using the cycle of care to guide him. First, he checks for an open airway and normal breathing. This responder finds the child is unresponsive and not breathing normally, so he begins CPR, moving through the cycle of care by beginning chest compressions and then rescue breaths. The emergency responder continues with care until EMS arrives.
6, 7, 8, 9, 10, 11.
Hi, Tanner. Hi, Tanner. You ever count your hand? Yeah.
A guardian suddenly discovers a baby isn't breathing.
Tanner? 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 1, 2, 3, 4, 5.
After 1 to 2 minutes of care, the mother alerts EMS of the problem.
Hi, my baby's not breathing and is unresponsive. 28.
She provides the EMS dispatcher with all the important information, answering their questions directly. By alerting EMS, an anxious mother gets advanced care on the way.
4, 5, 6.
As an emergency responder who knows how to handle situations involving injured or ill children, you can make a difference and offer the assistance that may improve a child's chance to survive and recover. Hopefully, you won't ever have to use your skills. But if you ever do, you know that you have the ability to help a child in need.